Hey everyone, we are going to give you a look inside the arteries as your doctor sees them. So excited. We have our world renowned RVT, Denise Levy here. This is P.A.D. test breakdown. We're not going to break down your results. We're going to give you a little extra special sneak peek inside your arteries because Denise has brought us some really great imaging that will kind of let you know what happens when you go into a procedure where they're trying to open up your arteries. So, Denise, I'm really excited about this. So, as an RVT, you actually go into procedures and you perform ultrasound as well. So, doctors not only use contrast fluid to light up those
Yes.
vessels, what do you do with ultrasound when
Well,
you walk in the room? What's the purpose?
well, the main purpose is if a patient cannot tolerate a lot of dye, then we can do a lot of the imaging on a sterile leg with a sterile ultrasound probe and put it directly on the leg and look at it. We can measure the artery and know how big the balloon needs to be. It's very similar to doing an IVUS where they do the operative on a catheter.
Yeah.
This you can put on the leg and simply image where they need to go. You can guide them with the guide wire, you can guide them with a balloon, and in some cases, the atherectomy.
And I think this is so important because there are a lot of patients that are chronic kidney disease patients. They end up with
Yes,
below the knee disease, and the doctor says, I'm sorry, you're in stage four, kidney failure here, kidney disease. And we don't think it's safe to put in a lot of contrast fluid. So bye bye, go home, you know,
they can use
do what you do,
CO2 as
palliative
well.
care. Yeah,
Yeah, they
CO2
can
is
use
definitely an option.
CO2. Is an option. But
But
it
this is
really
something that
does guide the surgeon to know where they're going.
it's amazing
So
what you can actually see.
this is a balloon that's inflated. On the right, the blue arrow is the wire. That's actually the wire inside the artery. The red is the balloon profile. That's the actual edge of the balloon blown up. And then the yellow there, we measure the actual size of the balloon when you inflate it. So what we usually do is measure the artery first, get the size balloon that we need to, because they come in different diameters and different lengths. And you put it on the wire, feed it up, and you inflate the balloon. And then you can see to the near the blue arrow, you can see the bottom of the balloon. You can see the profile of it tapering off. So this is what we use before you would use atherectomy. And it's very successful with soft plaque. With calcium, sometimes you need a scoring balloon to actually fracture and open up the calcium itself. But yeah, this
Okay,
is
but at
exactly
least
what we see.
this is amazing how much you can see from an external ultrasound that is on the skin,
Exactly.
right? You're viewing it
This is
from
on
the
the
skin
skin.
down.
Yeah, that
This
top
is
line is the skin
pretty
level.
amazing. So if
So
someone
this
has
is
chronic kidney disease,
not very far into the body. Um,
is
but
this
yeah,
something
this
that
is
a patient should ask their doctor to say, "Hey, well, what about ultrasound guidance for a procedure as an adjunctive approach to minimize the use of contrast fluid?"
Yeah, many doctors use this. Jill Somerset and I started
She's
using
another
this
world-renowned
years ago.
RVT.
Yeah,
Yeah.
it's wonderful. Yeah. So when they're in a tight situation, you can guide the surgeon just by using the ultrasound on the leg. So the next one, we have another video here. I'll pull up a video. This is a CSI system going through some very calcified lesions. You can see the bright white is the actual plaque. inside the artery. This is below knee. This is like a posterior tibial artery. You can see the wire going through there, and it's got a very small area to channel through. And the spinning sand, it's kind of like sandpaper on this
Yeah,
head of this device, the
exactly.
CSI.
It's an electric sander is what I
And they
call it
use
that
they
rotates.
use nitroglycerin because 100% of the particles go downstream to the foot and then go out through the vein. But this is a widely used device in coronaries and lower legs, and it's specifically for calcium.
You
You
can
couldn't
see it
use a balloon
pulling.
on this. A
There it
balloon would
is.
just expand it a little bit, but it would just come right back because it's hard plaque. Those
Yep, so they just
little
wanna
white
sand a little
areas,
bit of it down.
those are individual crystal plaques.
But this is how the doctor sees it, so that when they're in your
Yes,
arteries and is
yeah.
this still the ultrasound that is
That's
you're
the
using
ultrasound
ultrasound here?
on the
Oh, wow,
calf.
so you can really see it. Oh, wow,
Yep,
okay. So
yep,
people can barely see, it's almost it's like a blurred, you have to really know what you're looking at, and in the CSI, you have to look very carefully, and it's moving, it's almost like looks like a
right.
little moving
Yeah.
blur, like, it's
It's
almost the
it's like a
size of a
shaving, where you feed it through and you shave, the plaque itself, and
yeah,
you
you can
may
see the
just do
plaque of the
1 or
white on
2
the side.
passes. Yeah,
Yep,
and then what you would do is, after that, you would balloon it again. If it doesn't stay open, they put a stent in. But, yeah, you can see the wire and the head of the catheter going through that plaque.
yep.
So when they first start a procedure, if they're going through the groin or the ankle, they always image with ultrasound to see the sheath go in and then pass the wire. And some will prepare the leg so you can scan the whole leg, or they prepare the leg so they can do the ankle. Now, this is an in-stent stenosis with laser. So the top of that, the little dot there, that's the head of the laser. It goes through and it actually takes and changes the makeup of the plaque. It softens it and it obliterates it. So this is a widely used, it's the only device that is FDA approved to be in an in-stent stenosis. So
Right. So when your stents
laser
are
is
blocked and a
very
doctor
effective.
says, right, that it can't be done, it's always worth asking, especially before the procedure, say, what are the tools and techniques you're planning to do, right, to open up that stent?
Right,
Are you using a laser? And it seems the standard protocol these days for most of the doctors is to use a laser such as this one
right,
and a drug coated balloon that
correct,
follows.
correct. Yeah, so you can see the knee there. So this is a femoral artery in the
Interesting.
thigh, and it's coming down and it's treating the plaque, the soft plaque. It's usually neointimal hyperplasia. So the laser is very effective in this technique.
It's really interesting. I wanted to, I
This
know that
is
you guys
this is what the
heard
doctor
this.
would see on the screen with real-time angiogram. So this is what
Okay,
we
so
call a
this is
cine
not the
loop.
ultrasound.
This
This
is
is
not with
the
the ultrasound.
actual
This is an
angio.
X-ray, moving X-ray fluoral, we call it. And they use that all the time during a procedure.
And you can hear
We
that, and
use
if
it
you hear this
sparingly.
sound, it's loud during a procedure.
The laser is loud. Yes, it is.
Yes. So you know
But
when it's being used.
it's a wonderful procedure.
They're doing a lot of things with lasers these days. You have
Yes.
quite a few companies. They're now actually combining laser with shockwave, the
Yes.
audio wave
That's
technology
right.
that cracks the plaque. And so it'll be really interesting to see what new devices come in the next couple of years, but that still use the laser as the source of energy for those devices. So
Yes.
but this is really cool. So this is what when I traveled the world to all the nearly a dozen countries, more than 30 states watching the procedures. This is really what I would see. This is what the doctor sees when they're going through your arteries. This is exactly what they see. And this is how an atherectomy device, which Denise had talked about, an atherectomy device, the roto-rooting device, the device that ends up just taking out some of the plaque, or in this case, it's photochemical ablation, I believe, in this particular
Yes,
case when it comes to an excimer laser. But
yes,
you have Philips that you see in the corner that has one of these lasers. Angiodynamics has one of these lasers, and they work the same. They need a wire. So in order for these devices to be used, they need a wire to actually be able to cross the plaque. So sometimes
yeah,
in a situation where you have a 100% occlusion or 100% blockage, if a wire cannot get through, these devices can't typically get through. So it's always key to have at least a little bit of a channel for that wire to be able to navigate through. And then these devices, right, Denise, they slip right over the wire to help them navigate.
that's right. It follows the wire. Wherever the doctor puts the wire, it follows the wire. But it's a very safe device because it's not cutting into the
Yeah.
stent. And oftentimes there's a lot of plaque at the distal and proximal and mid portion of the stent. That's where most of the disease, it's scarring. If you have a stent, sometimes you get scarring within it, and it's called intimal hyperplasia. And usually it's not calcified plaque, but it's soft plaque. So it's very treatable with laser, and we make several passes with the laser and different intensities and different time. So it's
And I
very
always like to
effective.
just um, remind everyone that just because you have a blocked stent, though, doesn't mean that you need to have it opened up, right? A lot of times with these procedures, you may end up with a stent, once they open up your artery, maybe they balloon it, maybe they use a little roto-rooting devices, follow with another balloon, whatever it might be, and then they realize they need a stent. And you're having this procedure to just get you enough blood flow to um, relieve the pain, maybe heal a wound, but enough to get you walking so that you can grow those collateral vessels. So if they end up blocking up again, hopefully at that point you will have built enough collateral vessels that you may not need that stent opened up or reopened, because we have several
Well,
patients
yeah,
that
it depends
have
how
that.
long it's been occluded with the stent, because that's why when we put a stent in, we follow up within 6 weeks, because we want to know if the stent is still wide open after 6 weeks. They're usually on a statin as well. And if
Yep,
this
and
if the
possibly an
stent
antiplatelet.
has been occluded for like a couple of weeks, you can most likely open it. If it's been a year, you may not. The plaque or the scarring becomes like cement.
Mhm.
But oftentimes you can open them.
It was interesting. I was in Utrecht, and we were watching a case, and the doctor says, "It's like tire rubber. It's like tire rubber." He says, "Where's the Michelin man?" And I was like, "Oh
Right,
my gosh, he knows
right.
who the Michelin man is." But he said
And
it was so tough to get through, and they were able to do, and this is a little inside baseball, but a little step and repeat through. But it was like,
yes,
get the laser and then try a little bit of a balloon to see if it could eke open a little bit more, and they just step and
yep,
repeat,
yep,
inching their way all the way through
yep,
this blockage. But man,
that's right.
that took forever. Not every doctor has the patience, and not every
You have to
patient
have, yeah,
is
you
ready.
have to have patience, and you have to have good people there to support a product, and to, guide the doctor as to, what level set the laser at when you first start out. You start low intensity, and then you can increase the intensity as you go. But yeah, I learned a lot with that. It was a it's a great technique.
I love that you said they have. It's all about timing with these lasers, because I remember, not to scare anyone, but I was in one procedure with a laser, and the doctor starts going, "Do you smell that?" And I was like, "What do we smell?" He's like, "That's burning flesh. You can't go too fast with it, and you can't go too slow." And I was like, "Oh That's not good.
Mm,
So you
mm.
have to be, you always, and that's why we always say, make sure that the doctor has a lot of practice, not necessarily on you, with any particular device. Ask about the devices ahead of time, know what they have, know how they mitigate any sort of potential complication before going in. There are a lot of risks with every procedure. Even the best doctor can have a moment and have a complication happen, and so that's where we have bailout stenting, where they end up where they don't want to place a stent initially, but then if they have a complication where an artery gets dissected or perforated, which happens all the time, and you may never
Well,
know it,
yeah,
they
a
just place a
balloon,
stent.
you can get a dissection very easily from a balloon, very easily,
And
because it
that's why you
stretches
talk about
it,
the size of
tears
the
it.
vessel, right?
Yeah, but it's some do need treatment, and some will heal on their own if they're really if it's a small dissection, then you don't need to treat it. It's fine.
But
Yeah,
that's why ultrasound is so amazing, almost full circle here, but that's why it's so important that the
yeah,
physician uses some sort of ultrasound, whether it's intravascular ultrasound
that's
or
right.
ultrasound, external ultrasound as guidance, just to get for an additional measurement of the
Right,
vessel
right.
to make sure they have the right size products.
Yeah, exactly. And you change wires, you get a gold tip wire or you get a different wire that will push through the plaque. And but what really helps is guiding the doctor so that they can turn the wire, maybe have it face up, maybe face down to get through a plaque. It's really a valuable technique. Saves a lot of
Thank you
time
so
with
much.
the fluoro as well. So
I
X-ray
appreciate it.
is P.N.T. Wells was a famous scientist for
Yes.
ultrasound, and he told me a girl's best friend is the inverse square law. Greater the distance, the greater the protection. And that's true with X-rays, you know. But
That's amazing.
yeah, I definitely say that the laser is incredibly safe. Patient doesn't feel it. Um, they usually are, half asleep, but
Yep.
they don't feel any of these wires going in. You
Yep.
simply don't have nerve endings inside your artery. So you don't
Sometimes
feel
they
it in
may
the,
feel the balloon though.
they feel
They're
the pressure of the balloon. Yes,
Yep.
they will feel the pressure of the balloon. But
Especially if there's a lot of plaque.
it's only a 1 minute inflation time.
Yep.
It doesn't, it doesn't seem that long when you
As always,
inflate
take
it
a
and
deep
hold it.
breath if you feel it, but if it's too much, it's a good indication you need to say, "Hey, that's too much." And that's why you're in twilight versus completely out in a lot of these procedures, is
Correct,
they need to know what you're feeling during the procedure
correct.
so that they don't dissect the vessel.
Right, right, exactly. Yeah,
Thanks so much,
but
Denise. We really
oh,
appreciate
you're
you.
welcome.
World-renowned
Yeah, thank
RVT,
you.
Denise Levy. Make sure you do email us at info@padhelp.org. And Denise is graciously volunteering her time to check out your images for PAD, your ABI test, or your ultrasound. She can even take a look at the CT scan, maybe even your case notes from your CT angiogram and tell you what you're seeing. We're not here to diagnose. We're just here to define and help you to prepare for your appointments with critical questions to have ask your doctor and have a more productive and satisfying conversation. But thanks everyone for joining us. Don't forget, like this video, subscribe to our channel. It really helps us a lot to get the word out and spread awareness about PAD, and that there is a resource like this available to help patients in between appointments reduce their anxiety and help to come up with some great questions to have that productive conversation with their doctor. So thanks everyone for joining us.
Thank you.